Dear students, now we are learning urinary bladder. And what I am showing you at the moment is a boat. Why I am bringing a boat when I am explaining the urinary bladder? I have a reason for that. Now I have cut this boat. Why? Because it resembles my urinary bladder. And to understand urinary bladder, I can imagine something like that. We all know this part of the boat, what it is called the dock, and then these are the two surfaces, and they are resembling exactly like this. So now my urinary bladder, it looks like this much part of the boat, and these surfaces on both the sides, they are called inferior lateral. These are the lateral surfaces, but they are slanted. They are slanting and they are widening up on the top. So these are the inferior lateral surfaces present on both the sides. There is an apex and there is a base and there is a superior surface. And then bladder continues, urinary bladder continues as urethra. Looking further, this is a better image where you can see the muscles and you can see something special. So this grayish thing which is present only on the superior surface of the bladder, that is parietal peritoneum. So the superior surface of the bladder is only covered by the peritoneum, the inferior lateral surfaces, the base or the posterior surface, and the other areas are not in contact with the peritoneum at all. And you can see these ureters, they are opening on the sides. And this continues as the urethra. And bladder looks like more a tetrahedral shaped structure. Now, this is the pelvic cavity and there is a urinary bladder. To understand, we should take it out. And now you can see, you can apply the superior surface, you can look into the inferior lateral surfaces, the neck of the bladder, and then it continues as urethra, and then the posterior surface or the base and the apex and the ureters. And there you are looking at a urinary bladder from the top. And now a male urinary bladder, we have something, a small walnut shaped structure on which the whole urinary bladder is sitting, and this is nothing but the prostate gland, and through this prostate gland we have the passage of the first part of the urethra, and you can see the label picture of the same. And there the bladder has been opened up, you can see the thick wall musculature, and these are what muscles are these? These are the detrusor muscles, and you can see this inner core is the mucosa, and then we have, this is the mucosa, this is the submucosa, and these are the detrusor muscles, and we all know what is the lining epithelium. Look at it, these are the openings of the ureters in the lumen of the urinary bladder, and look at the wall, the mucosa and submucosa. The mucosa is not flat, it is wavy, some rugy like pattern, but it's not same like stomach. And you can see that at the bladder neck, this triangular area, what is this called? This triangular area is called the trigone. Trigone is different. It acts like a sensor. We have the urine coming into the cavity of the bladder, and after a while a sensation starts going to our brain, and that will tell us there is a urine which is present in the bladder, and then we look for appropriate place to empty out the bladder. And it is really important, once you have this sensation, don't delay, don't wait. It's better for your health and well-being that you should evacuate your bladders all the time. And then this is the beginning of the urethra, and this is within the prostate, we call it prostatic urethra. You can see here there are so many structures, but we are not talking about them at the moment. But these are important, and I'll be covering them in the next lecture, where I'll be talking about prostate and urethra. And then this is the label picture. And now we are just focused at the bladder neck. Look at, we have some special type of muscles which are arranged here, and these muscles are acting as sphincters, and sphincters are the one which keeps a control on our urinary bladder, and we are not leaking urine all the time like small babies or the old age people. And then look at these two tubes which are entering separately. These are the tubes who are coming from the testes, vas deferens, and then these are called the ejaculatory duct. There we have the seminal vesicles, and then from there the sperms has been flowing, and these tubes are opening in the prostatic urethra to transmit the semen, so that at the time of ejaculation it should pass out. So the urethra is used for two purposes. One is for the passage of the urine, and second is for the passage of the semen. That's why the males have two sphincters, because at the time of ejaculation this sphincter has to be closed. Otherwise, what will happen? The semen can go into the lumen of the urinary bladder rather than going front, and then if that happens, that is called retrograde ejaculation. Ejaculate is not going forward, rather it will go backward. And this problem occurs with those people who have the weakening of this internal sphincter. Internal sphincter is not well developed in females. So female only have one sphincter, and that is the external sphincter. And we'll be talking in detail about these sphincters. One is voluntary and one is involuntary. I'm sure everybody knows what is voluntary and what is involuntary. So this is a labeled picture of the same. We can see the prostate, prostatic urethra, the ejaculatory ducts, and the two sphincters. Now, this is a female urinary bladder, and how it is different from a male, we don't see any prostate. Prostate gland is never present in the females. And this is the labeled picture, and female urethra is always short. And you can see that the female urethra, and there is only one sphincter which has been shown here. And the female urethra is very close to the vaginal opening. That's why urinary tract infections are very common in females as compared to male. Now we are looking at the inside. Inside is the same. They have the same ureteric orifices. They have the same trigone. They have the bladder neck and the urethra, but their urethra is short. Okay, so now let's take a look at how these structures are organized in the pelvic cavity of a male and a female. So I'll be starting with the male option. This is the pubic symphysis, sacrum. This is what? Linea alba. We all know what is linea alba. We have done it in the GI with the anterior abdominal wall. I'm sure everybody knows the place where the muscles who makes my anterior abdominal wall, and what were those? External oblique, internal oblique, and transversus abdominis. They meet in the midline. That point is the linea alba. You can see that inferiorly it's attached to the pubic symphysis. And then this is the urinary bladder, and the apex part of this urinary bladder, it goes upwards, and this grayish part is given a name, and that is called as the urachus. This is the ruminant. And the cavity of the urinary bladder, and there you can see the urethra. And male urethra is long, it is not straight, it is S-shaped, and female urethra is straight, and that is very short as compared to the male urethra. And now I am putting up so many muscles here, but I'll not be talking about them. Now you're looking at the prostate, and this is the prostatic urethra. And at the base or the posterior surface of the urinary bladder, you can see these sacculated structure. This is nothing but the seminal vesicle. That is a reservoir, a storage place for the semen, for the sperms. And then these are the different muscles who contribute in making the penis. We are not talking about that. We will be discussing this stuff with endorepro block, inshallah, second year, first block. And then there are other muscles. And now this is where the posterior structure, the structure which is related to the posterior surface of the urinary bladder, is the rectum. And then there is a muscle sling. You can see that this muscle is going all the way, and that is levator ani. And this levator ani is a really important muscle. And these are the sphincters. These are the one who controls the anal canal. And this is the strongest muscle in human body. The last thing which we lose is this sphincter. And this levator ani muscle, along with the piriformis and coccygeus, it made another diaphragm. Our body has 4 diaphragms. You have learned one abdominothoracic diaphragm. Now today I'll be showing you the pelvic diaphragm. And who contributes in making of this diaphragm is levator ani muscle, coccygeus, and piriformis. We'll be talking in detail in second year, not here. And now what is this green structure? Is it peritoneum? No. This is endopelvic fascia, which is derived from fascia transversalis. And now this thing is the Parietal peritoneum, as we have discussed already, the superior surface of the bladder is only covered by this peritoneum. This is parietal peritoneum. And you can see there is a dip which has been shown in front of the rectum and behind the bladder. This dip in part is called vesico or rectovesical pouch. Rectovesical pouch. Don't confuse it with pouch of Douglas. Pouch of Douglas is only present in females, not with the males. And now the other male tissues, we are not talking about them at the moment today. We all know this Camper's fascia, we talk about in GI. I'm not talking about it here. And it has a membranous layer and a fatty layer, the scarpas, and it has different names when it goes in different locations. Are we good so far? Now, let's look at a female pelvic cavity and let's see what are the difference between a male and a female pelvic cavity and organization of the structures. We know there is an additional structure there. Let's see. Pubic symphysis, sacrum, same linea alba, same urinary bladder and the urethra, but see the urethra is short here. And then this is the urethra, and look at it, urachus. They also have a urachus. And now the uterus, it's sleeping on the superior surface. It has been bended forward, flexed here, and it is sleeping on the superior surface of the urinary bladder. This is the uterus and this is the vagina. The fundus part, then it has a body, then it has a cervix. We'll be talking second year inshallah. And now these are the same muscles and there's a rectum behind. So in the female pelvis we have more structures. Along with the rectum and the bladder we also have the uterus and vagina, we have to accommodate them. Levator ani is the same. It's really important. Pelvic diaphragm. Females, anal sphincter. Now this green thing we all know, this is endopelvic fascia. And this is the peritoneum. Now you can see that there is vesico or utrovesical pouch, same like males, but recto-uterine pouch is only with females, and that is pouch of Douglas, and it has a significant clinical correlations, and you need to be knowing them when you'll be doing endorepro block, not today. So you are looking at the recto-uterine pouch and vesico-uterine pouch. I'm sure it's good so far. Okay, let's proceed. Now a urinary bladder has been opened up. And you are looking, it's opened up from the front. And you are looking at the posterior wall and the lateral walls and the base. The place, the bladder neck, you can see the trigone, you can see the ureteric orifices, interureteric bar, and you can see the beginning of the urethra. And this is prostate, so this is not a female, this is a male urinary bladder. This is the urachus. And these are the different structure which we'll be talking when we'll be talking about the prostate gland. Now, this is a coronal or frontal section. Now I have zoomed into this area with the help of an endoscope, and this is how it looked like. This is a real picture, a real live picture, an opening of the ureter on the right side. And this is a female urethra. Look at it, the length is very short. Now, a coronal section or a frontal section. We know these bones, urinary bladder in male, levator ani, prostate gland, a plexus of veins surrounding, really important. And you can see the detrusor muscles who are contributing in making, because these muscles when they contract, at that time urinary bladder empties out, and this is the mucosa which lines inside. And the internal urethral sphincter, the openings of the ureters on both the sides, trigone. Guys, trigone is important. And this is the prostatic urethra. We have talked about it. Guys, don't forget to read these green lines. They are important and they will help you to understand so many concepts. Now, the other structure which I am not talking here. So female urinary bladder. Similar features other than the urethra is short and there is no prostate. Rest is the same. There is no difference. Same trigone, same bladder neck. I'm sure it's all fine with you guys. So now, the posterior surface, guys, this is a very important slide. We always ask this concept. What are the structures related to the posterior surface or posteriorly to the base of the urinary bladder in males? So, you can see the prostate, it's below, but to the posterior surface, the posteriorly related structures are these two tubes. This tube, you can see these are the vas deferens. These are not ureters, and these are the ejaculatory ducts. This is the seminal vesicles. The vas deferens, it's ampulla, and then the seminal vesicle, they join to form ejaculatory ducts. And I have shown you previously, these two ejaculatory ducts, they join and they open into the prostatic urethra for the transmission of semen. And these are the vas deferens, and you can see that the ureters are coming down to be emptied into the urinary bladder. The ampulla part of the vas deferens or ductus deferens, and this is the seminal vesicle, and you can see inside there are cave-like appearance. And this is the beginning of the ejaculatory duct, as I told you, and this is the urethra. Now, another important concept, the blood supply. What are the arteries and veins who are supplying oxygenated blood to the urinary bladder? You can see a big contribution. Primarily, this is what common iliac, and this is you're looking at the internal iliac, and this is the external iliac. We learned that external iliac, when it passes under this inguinal ligament, we call it femoral, that is outside. But inside the pelvic cavity, the internal iliac artery, it breaks up into so many branches, and you can see that we have so many contributions coming to supply this urinary bladder. This is a male example. And then you can see that this is a label version. You can see the superior vesical artery, you can see the inferior vesical artery. There's a list of the arteries, and you are expected to be good with that. I have next slide will be talking about that, but first you'll see when we'll remove this bladder how the appearance will be. So now the urinary bladder has been cut, and you can see how the branching of the internal iliac artery, and it's been contributing to the different organs. This is a female example, and you can see that they are going everywhere. So this is the labels of the same stuff. So now, in short, the main artery who supplies the bladder through its branches is the internal iliac artery. Primarily, the contributions are coming from superior vesical artery, obturator artery, and inferior gluteal artery. So these are the main three arteries who are supplying my urinary bladder. But I have certain differences between males and female example. So in the males, inferior vesical artery supply the fundus and neck of the bladder. But in females, the vaginal arteries, they replace the inferior vesical artery, and they send small branches to posterior and inferior parts of the bladder. So in females, we have contribution, instead of inferior vesicle, we have vaginal artery. So that is a replacement, and that will be responsible to supply. And obturator and inferior gluteal will remain the same. So you are expected to be good, and you should be expected to differentiate in males what is the replacement, in female what is the replacement for inferior vesical artery. The vaginal artery we don't have in the males, and inferior vesical artery we don't have in the females. So these are the terms which are interchanging, and you are expected to be good with them. Now the venous drainage, very easy. They follow the same names of the arteries, and these are not, we don't call them branches, these are the tributaries of the internal iliac veins. They ultimately drain into the internal iliac veins. Now comes one of the very, very important concept, and it's really important, and that is the nerve supply of the bladder. Guys, with the bladder, if we talk and if we don't know about, one, the structures related to its posterior surface or the base, one. Second, what is the nerve supply and what is the mechanism, the controls and everything, that is a must know type of information. So now let me draw a coronal section of a bladder and a urethra. And let's put the things here, and this is important for you to understand. And let me put the labels here one by one. So now what I'm showing you here, can you see this blue thing? This blue thing is the internal urethral sphincter. I told you in male urinary bladder we have two. We have a set of sphincters because this one is responsible to prevent retrograde ejaculation, and then we have external urethral sphincter. We have a set of sphincters. One is voluntary and one is involuntary. So let's establish that. And this is the external urethral sphincter. And now you can see that I'm bringing up what? The sympathetics, because when we talk of voluntary and involuntary, there we should be autonomic nerves. We all know the parasympathetic and sympathetic. So from T11, 12 and L1 and L2, I'm driving what? The sympathetic nerves. So they are coming down and they are relaying where? Into hypogastric or vesical plexus. And now what are they doing? Can you see that? They are relaying into this rounded structure, and that is hypogastric and vesical plexus. So now let's explore. When we talk about the motor innervation of the urinary bladder, so there we talk parasympathetic and sympathetic. So right now I have shown you the sympathetic. So what is being said, sympathetic fibers are derived from, you can see yourself, T11, T12, L1 and L2. And they are inhibitory. Inhibitory means they close. They are inhibitory to detrusors. So they are giving minus effect to the detrusor. But on the other hand, and they are what? They are closing. They are inhibitory to detrusors and motor to the sphincter. Inhibitory here and motor here. Who? The sympathetic fibers. So this is one aspect. Let's go further. This is S2, S3 and S4. And these are the sources of why? What are these sources of? These are the sources of my parasympathetic. And what they are doing, the parasympathetic we know S2, S3, S4. And they are what? They are motor. So that is a reverse. So let's put them here, and they are relaying also into a ganglion. And that ganglion, what is the name for that? So that ganglion is called what? That ganglion is the vesical plexus. And these parasympathetics, basically they are doing opposite. My sympathetic was inhibitory, and now here with the parasympathetics, they are motor to the detrusor and they are inhibitory to the sphincter. So the mechanism is reverse. So you can see that the plus is here and minus is here, and that goes reverse in this part. And now what I'm showing you here, this black thing from S2 and S3 segment, and these are the somatic fibers. And what are these somatic fibers? This is basically S2, S3 and S4. This is what I'm trying to show you is the pudendal nerve. And pudendal nerve is controlling what? My external sphincter. Now you should be able to differentiate. The external sphincter is voluntary. It is in our control. But internal sphincter is involuntary. That's why it is being controlled by sympathetic and it is controlled by parasympathetic. But the external sphincter, which is controlled by pudendal nerve, and that pudendal nerve is nothing but a somatic nerve. Are we good with that? So they are motor to the external urethral sphincter. So now the sympathetic innervation, in short terms, the sympathetic innervation is responsible for filling of the urinary bladder. So when we have to fill the urinary bladder in that state, the sympathetic time, that is the time where bladder is filling. So in physiology, they will be explaining about filling phase and emptying phase. So sympathetic innervation is responsible for filling of the urinary bladder. And parasympathetic is the time when there is a parasympathetic play. It's the time where bladder is emptying itself. And you need to understand. And somatic innervation or pudendal is responsible for voluntary control of your urination. So you can control this sphincter, but you cannot control. So this nerve is responsible for filling phase. So when there is a filling, this sphincter is closed. And once we are voiding, this sphincter is open. Are we good with that? So we need to understand the nerve for filling of the bladder, the nerve which is responsible when bladder is filling, the sympathetic. Think of the normal situation. You are under stress. A lion is in front of you. You are in a fear. Do you feel like voiding? No. But once you are relaxed, once you are at your comfort, now it's the time where you think about, oh, I should go to the toilet, I should do this and that. But once you are in a stress, you lost everything. So this is important, and that you should be knowing. That's really important. So internal urethral sphincter, we talk about it. External urethral sphincter, we talk about it. Hypogastric and vesical plexus, we talk about that. Detrusor muscle, we all know about that. Vesical plexus, we know about that. And we know this is the parasympathetic pelvic splanchnic nerves. This is the pudendal nerve, which are the somatic nerves. And this is my vesical plexus. Now one question, how my brain knows that bladder is having some urine inside? And that is coming through the sensory innervation. And this sensory innervation, so majority of the sensory fibers run along the parasympathetic fibers through pelvic splanchnic nerve, and these are called nervi urgentis, S2, S3 and S4, and some fiber run with the sympathetic fibers. And primarily we have two type of fibers. So fibers are a set of fibers who are connected for the pain sensation, and fibers who are concerned with the conscious awareness of filling of the bladder. So they tell our brain that there is a urine and you should look for a toilet, look for a hammam, and go and empty it out. So the pain fiber runs into the anterolateral wide columns of the spinal cord. Fine, you will understand this when you will be doing your neuroblock. But simply you should remember who controls when the bladder is filling. Sympathetic is, this sphincter has to be closed. And this is under our control, under our will. But this is beyond our control. And this is a real important concept, and you are expected to be good. So I'm showing you these blue lines, what are those, and what are the red lines, and everything we have just talked about. So sympathetics, parasympathetics, and somatic. I'm sure this concept is clear at the moment. If not, please, you are expected to learn in a more way. So now, last item. This is the normal urinary bladder, and there you can see the urethra. So this is a normal bladder, everything is fine. What happens? Why this balloons up? There is some problem. Urethra has been blocked for any reason. We are not bothered why it's been blocked. It is blocked. So now bladder cannot empty itself. And urinary bladder is filling and filling and filling. And as a result of that, what happens? Look at it. So bladder balloons up. So now superiorly we have the parietal peritoneum. And look at it. If I was accessing bladder at this moment, I could have encountered these loops of small intestine. It was hidden behind the pubic symphysis. But once it's filled, you can see it has gone all the way up and it has pushed all these loops of small intestine. So now bladder is accessible from the anterior abdominal wall if I stay in the midline. So we can insert in this situation when the urethra is blocked for any reason. So we can put a needle here and we can do a drainage. This is one of the very important point, and we need to understand that. So this is called what? Suprapubic catheterization. When we are doing it, when there is a damage occur to the urethra, or prostate gland is super enlarged, or there is some stone which has impacted, which was coming all the way from the kidney, passes through the ureter and impacted, stuck in the urethra. Now patient is unable to pass the urine, patient is in real distress. This is one of the really important situation, and there is no comfort, nothing works. Only if you don't empty this bladder out, there is no solution. So for that reason, I have inserted a small video which will helpful to understand how we do this suprapubic catheterization. So stay connected. So you are looking at a urinary bladder which is distended. You can see that the urethra has been closed here and no urine can pass out from the urethra. And now how we access it, this is the male example. So for that, I can show you this video. Suprapubic catheterization, and you can see that a normal situation, but this bladder is full. So we can put a needle from the midline, and you can see that we have aspirated out, we put a tube in, and then over this tube, we insert a sleeve in. So this sleeve is being pushed into the bladder. And now we remove this wire outside, and through this, we insert a tube. This is called a Foley's catheter. We leave it inside and we connect it with a bag First, we fill this channel and you can see a balloon will appear here. So this balloon will fill up. Now this tube will not fall out. We remove these and then we connect this to a bag. This is called a drainage bag and you can see the urine has been filled up.